welcome to meeting number 131 of the House of Commons Standing Committee on Health. Before we begin, I would ask everyone in the room to read the guidelines printed on the cards on the table. The measures are in place to help prevent audio and feedback incidents to protect the health and safety of all participants, including the interpreters. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8th, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have Dr. Sarah Larney, Associate Professor at the University of Montreal, online. Sarah MacDonald and Lance Charles are with us in the room. Representing the First Nations Health Authority, Dr. Cornelia Wyman, Chief Medical Officer, online. And representing the Vancouver Island Construction Association, Roy Kulmala, Chief Executive Officer, also by video conference. Thank you all for taking the time to be with us today. As you I'm sure have been informed, you will have up to 5 minutes for your opening statements, and then we'll proceed with rounds of questions. We're going to begin with Dr. Larney. Dr. Larney, welcome to the committee. You have the floor.
Thank you, committee members, for this opportunity to speak with you today. My name is Sarah Larney. I have a PhD in public health, and I'm an associate professor at the University of Montreal. My research focuses on the health and well-being of people who use and inject drugs, and I have conducted several projects that are relevant to the committee's remit. The most recent of these was an analysis of toxicological findings from people who died of overdose over the past decade in Quebec. These data showed that while Quebec was shielded from the worst of the toxic drug supply and overdose epidemic prior to 2020, this is no longer the case. In recent years, fentanyl is increasingly present in people who died of overdose, alongside a growing variety of highly potent and toxic compounds, including non-medical benzodiazepines, nitazines, and xylazine. The number of opioid overdose deaths in Quebec increased dramatically in 2020 and has remained high. There were 319 opioid overdose deaths in Quebec in the first 6 months of the year, compared to 236 in the same period last year, a 35% increase. The rate of overdose mortality is low relative to provinces in the west of Canada, but it is probable that the situation will continue to worsen as a result of the toxicity of the drug supply. We have also studied use of supervised consumption sites in Montreal since 2018. In this work, we found that the proportion of visits to supervised consumption sites requiring an overdose intervention increased markedly in 2020 and has remained high since. However, these overdoses were not fatal because staff were able to quickly respond, providing oxygen, naloxone, and further care as necessary. Supervised consumption sites must be a central part of the response to the overdose epidemic. The number of deaths that would occur without them in major cities, in regional areas, and across the country is unthinkable. The current overdose epidemic is often dated to 2014 or thereabouts. Recent work in the United States, however, has shown that overdose deaths have in fact followed an exponential growth pattern for nearly 40 years. Using publicly available data from Statistics Canada, we have identified a similar growth pattern in Canada, with an average increase in the overdose mortality rate of 9% per year, every year since the year 2000. There is no sign of this trend slowing down. I want to emphasize that exponential growth does not just mean rapid. It means a specific pattern that is underpinned by a process or processes that continually catalyze further growth. While the toxic nature of the drug supply is the immediate cause of the overdose epidemic, these underlying processes contribute to the sustainment and growth of the epidemic. These are most likely socioeconomic trends, things such as increasing housing costs, increasing income inequality, and declining income mobility. These trends intersect with and influence each other. It is not a coincidence that overdose deaths have increased in Montreal at the same time that housing costs have increased dramatically and income inequality has also increased. My point here is that well-funded, low-threshold harm reduction services are essential to manage the acute overdose crisis. These services, however, are hamstrung by a policy environment that permits growth in overdose deaths to continue. Interrupting this growth requires social policy reform, attending to the housing crisis, income stagnation, and other issues, including overburdened health systems, particularly mental health systems across the country. Drug policy reform is also essential to address the perverse incentives that drive drug traffickers to produce ever more potent substances. No single one of these issues that I have mentioned is the sole cause of the overdose epidemic, and no single policy will bring an end to this epidemic. Rather, it is likely that all of these will need to be addressed in some way and the social safety net strengthened if we are to successfully interrupt the epidemic curve. Thank you.
Thank you, Dr. Larney. Next, pleased to welcome Sarah McDonald and Lance Charles here with us in the room. You have 5 minutes for your opening statement. I understand that you're going to be sharing the 5 minutes, if I'm not mistaken. So you have the floor. Welcome.
Thank you. Thank you for having us. My name is Lance Charles. This is my wife, Sarah McDonald. She's the mother of Brianna McDonald. Brianna passed away on August 23rd from an overdose. She struggled with mental health, and it dragged her down pretty to a dark path. She was an amazing little girl. She had a laugh like no other child. She was there for you when you needed her. And around the time when I came into Brianna's life, Brianna started to experience issues with her mental health. She started experimenting with drugs as well. Her drug of choice was Molly, but would try anything she could get her hands on. Brianna had over 20 recorded suicide attempts. She tried to overdose on prescription drugs that she would steal. Over time, you could see she was going down a very dark path. We as parents started to discuss what we could do and try and get her help. We looked into treatment centers, mental health centers, doctors and counselors. None of it helped. The treatment centers would tell us that she was too young. The doctors would tell us she had behavioral issues. Others would tell us she's too young to diagnose. Brianna's father and I would beg doctors to keep her in hospitals. The doctors would overlook what we said and release her, sending us home with Narcan kits. This was really starting to get alarming. We spent every other week with Brianna at the hospital, it seemed like. She was prescribed many different medications and prescriptions. Some worked for a bit, others didn't work at all. We noticed things were getting darker. She became a ball of rage. She was up all night, sneaking around and doing her drugs. She started to come and go as she pleased. Sarah and I would often get woken up by the police, bringing her home because she was found extremely intoxicated. Police would also be needed when she would have her violent episodes and threaten to kill herself. An officer actually asked me once, what would I like him to do? I told the officer, she's threatening to harm herself. Please invoke the Mental Health Act and force her into a hospital. The officer told me he couldn't because that's against her will. This is when I discovered the Infants Act. This little girl had more rights to her medical decisions than her own parents. She could tell doctors anything they wanted to hear, and they would release her. Back in February of this year, Brianna was found in the kitchen overdosing. Sarah called 911, and an ambulance came a short time later to take her to Abbotsford General. Sarah got very mad when she was at the hospital. She stood up to the doctors who were just going to pump Brianna's stomach and send her on home. Sarah directly told the doctors, we are tired of this. And Brianna needed help with her mental health. This time they sent her to Children's Hospital in Vancouver. Brianna didn't do well there. She was lashing out at staff, screaming. They really couldn't handle her. They weren't fit to handle her. So they transferred her to a place called Cap Soo. It's at Surrey Memorial. They held her for about 10 days. While there, she did have her good days and she had her bad. Sarah had a meeting with the doctors. They told her Brianna was clear to be released, when realistically she wasn't. She had just finished putting a pencil through her hand. Well, they have been... Once again, Sarah fought to keep her there, and of course, all they did was send us home with a Narcan kit. This is when we started to see the real dark side of Brianna. We noticed she started using drugs like Molly on a regular basis. We were astounded that she could actually get these drugs. One evening, a car randomly pulled up in front of our house. I went outside after asking my wife who this person was showing up in front of our house. Turns out we didn't have a clue. We went out to look, or I went out to check and make sure and ask what this person's business was in front of our place. These were two 16-year-old children there to sell our daughter, Molly. So we took pictures of the license plates and reported it to the police. The police never did anything, didn't even report back to us. Now I was really getting worried. It was shortly after Sarah started wondering what else was she up to. So she started following Brianna around. Brianna would actually go to a harm reduction site, and she would acquire these Ziploc bags full of needles, cooking kits, and pamphlets on how to cook the drugs and safely use them. We were astounded the fact that these were available to a child. How can a 12-year-old at that time acquire these? She can't buy marijuana at a dispensary. She can't buy booze at a liquor store. But she's able to pick up these kits to use drugs from a harm reduction site, a site that is meant for people that are not children. It didn't make any sense. Now we have reached the darkest times just before she passed. Around the end of July 2024, Brianna became so violent towards her mom and I. And this was a direct result of not just the drugs, but her mental health had gone so far down a deep path. Sarah was destroyed seeing her daughter do this. We talked about it every night, trying to figure out what to do. Days later, Brianna became so violent with her mom and I. She got into a fight with her mom and actually caused some serious damage. Her mother ended up in hospital with a severe concussion and some serious brain trauma. I ended up with a black eye and a cracked orbital socket. Now her mental health was really in a dark spot because now we didn't feel safe with having her at our house when we have other children. So the police removed her from our house and advised that it was not safe for her to be around our other children because now she had become so violent. So they ended up taking her to a place called Cyrus House. And Cyrus House tried to hold her and keep her there. She stayed one night. The next night she didn't return. So Cyrus Center, when she didn't return, put out a missing persons report. This is when we found out she now wanted to be at a homeless camp. The police found her there. They didn't directly tell us that she was at a homeless camp. We found that out days later by ourselves. All they said to us was, she is safe, and she's with another adult who's nobody to us. We didn't know her, didn't even know her name. Since when is it okay for a 13-year-old to be at a homeless camp? Why didn't the police bring her back to Cyrus House? Why was she just left there with another adult that doesn't associate with us? We did keep in contact with Brianna every day. We brought her food, we bought her clothes, but she didn't want to return home. We tried to inflict rules, try to give her more stability and tell her that if she comes home, she's got to follow these. And she goes, "Why? I can do whatever I want out here." It didn't make any sense. You know, if she needed clothes, she needed anything, she could always reach out to us, and we were there for her. Now we come up to August 22nd, 2024, and August 23rd, 2024. I went to work on August 22nd thinking this wasn't going to be a change in my life. I was at work, and I worked night shifts at C-SPAN International. And my wife, who never calls me at 3 in the morning, I received the phone call, the one that a parent dreads. She started the conversation off with, "I love you very much." This is when she proceeded to tell me that our daughter had passed. This is every parent's nightmare. This is when we realized the system we have in place has failed her, and massively. The people she could go to for help failed her. My question, and always will be, is why are harm reduction places considered safe? Why our children aren't allowed, or not, I shouldn't say allowed, why is there no programs really in place for our children and their mental health? These drug addictions would have never become what they were if she could honestly get the mental help. She used to tell us she would have demons and voices in her head, and the only way she could drown them out was through the drug use. If I don't know about you guys here, but when you stand back and think about that, that is very alarming. That a child is using drugs to drown out voices in her head. The mental health problems were there, but anybody we reached out to weren't. They would send us home with Narcan kits. They would tell us that we can't force her into anything against her will. On September 19th, Brianna's friend, Shayton, very, very lovely little boy. They were best friends. They started experimenting with drugs because they both struggled with mental health. He had a very hard time dealing with the fact that Brianna was gone, to the point where he made a suicide attempt shortly before Brianna's funeral. And days later, after her funeral, succeeded. He is no longer with us. These are two 13-year-olds, two of them, that have passed. Now, not only because of drugs, but struggling with mental health. We need things to change because our children are dying, and we can't afford to lose any more children. I thank you for bringing us here to speak, and I hope Brianna's story, and as well as Shayton's story, can bring awareness to the struggles that our children are having, and to bring awareness to the parents that are struggling with children that are struggling. It hurts every day thinking about this situation, because I think if Brianna had access to the proper mental help, she'd still be here today and be able to tell you this herself. Instead, we have to speak on her behalf because she's no longer with us. It breaks my heart having to speak about a child that's no longer here. We do need change, and it needs to be now. Our children are dying, and no other parents should be going through this pain. And I hope today we can bring some answers and enlightenment to this subject. I thank you.
Thank you, Mr. Charles, and please accept my condolences and those of my colleagues on the passing of your dear Brianna, and also our respect for your courage to tell such a personal story in a public forum. And next, we're going to go to the First Nations Health Authority, Dr. Cornelia Wyman, for the next 5 minutes. Dr. Wyman, you have the floor.
Thank you. Good morning. Bonjour. Bonjour, Annie. I'm Dr. Nell Wyman. I'm originally from Mishi-Bewittagong First Nation in Treaty 5 territory, which is part of the Anishinaabe Nation. I serve as the Chief Medical Officer at the First Nations Health Authority here in British Columbia. I want to acknowledge that I'm speaking today from the traditional, ancestral, and unceded territories of the Musqueam, the Squamish, and the Tsleil-Waututh Nations. The FNHA is the first of its kind in Canada, created by and for First Nations people in BC to support their health and wellness. Since before the toxic drug crisis was declared a public health emergency in 2016, we have been on the front lines addressing the disproportionate impacts on First Nations individuals and communities that have worsened historical and systemic inequities and intergenerational trauma. Our role is to engage with communities and continue to expand our public health response to this emergency in collaboration with our health governance partners. Our data for BC First Nations people is alarming. In 2023, we lost 448 First Nations people to toxic drug poisonings. This was a 10.3% increase from 2022. First Nations people died at 6.1 times the rate of other BC residents. Women and young people are particularly overrepresented. Since 2016, we have lost 2,356 lives. These data are not just numbers. They represent our family members, our aunties, our youth, our elders. They are loved and missed. This is only the tip of the iceberg. There is a vast number of other substance use-related harms, such as acquired brain injury, disconnection, and mental, emotional, and spiritual distress. Between 2015 and 2021, life expectancy for First Nations people in BC fell by 7.1 years, driven both by the COVID-19 pandemic and the toxic drug public health emergency. This reveals the long-term losses and harms to our communities and the urgent need for critical action. FNHA's response to date has been rooted in cultural safety, community engagement, and innovative initiatives derived from shared learnings across our 5 regions. Our approach is community-driven and nation-based and supports a continuum of care that meets people where they are at in their wellness journey. We have developed and funded culturally safe community-based programming grounded in harm reduction, which includes expanded OAT availability, establishing peer support groups and outreach teams, funding First Nations-led overdose prevention sites, and increasing access to harm reduction supplies in communities. supported public education and awareness through our Not Just Naloxone training program and communications campaigns, expanded cultural programming, including through land-based healing initiatives, and funded rapid access to treatment and healing centers that incorporate culturally safe practices. While progress has been made, we continue to face significant barriers. These include the inaccessibility of substance use services in communities, particularly in rural and remote areas, and the lack of long-term sustained and flexible funding, including for cultural programming. We cannot ignore the role racism and discrimination play and the lack of recognition of the intergenerational impacts of colonialism, resulting in culturally unsafe healthcare. This is further compounded by the stigma surrounding substance use, which prevents people from accessing care. In closing, the toxic drug crisis of 2024 is more deadly than it was 9 years ago. The major driver of deaths is due to the increasingly unpredictable, dangerous, and potentially lethal unregulated drug supply. The politicization of this emergency threatens progress, especially against the backlash against proven evidence-based harm reduction measures that can save lives, hits First Nations people the hardest, deepening existing inequalities. Every loss is felt deeply by families and communities, and we call upon our system partners to implement timely solutions which are First Nations-led, culturally safe, trauma-informed, and appropriately funded. I thank you for your attention today. Thank you. Merci. Miigwech.
Thank you, Dr. Wyman. Next, the Vancouver Island Construction Association, Rory Kumala. Mr. Kumala, welcome to the committee. You have the floor.
Thank you, Mr. Chair. Again, I'm Rory Kumala, CEO of the Vancouver Island Construction Association, where I have the privilege to work and live in the traditional territories of the Lekwungen peoples, and that the historical lands that we have a relationship with through the Songhees, Esquimalt, and WSÁNEĆ peoples continue to this day. 2024 marks the 8-year anniversary of the state of emergency declared by the BC government in 2016 in response to a dramatic increase in overdose deaths that year. Toxic drug poisoning from illicit drug remains the most prominent cause of unnatural death in British Columbia, greatly surpassing those to suicide, motor vehicle accidents, homicide, prescription drug overdose. In 2022, the BC Coroner's Office released the report BC Coroner's Services Death Review Panel, a review of illicit drug toxicity deaths, which outlined some important demographic trends among the representative sample of British Columbians lost to the toxic drug poisoning. An important finding of this report that was trends in employment by sector. Of those employed in their time of their death, 52% were working in construction, trades, transport, and equipment operation. The high number of drug poisoning deaths represented the construction industry has been in part attributed to substance use and consequences of strenuous work environments with long shifts and pain. Stigma is pervasive in the construction industry, as is the real barrier to accessing treatment, resources, and harm reduction supports, including those for mental health. The Tailgate Toolkit project, which we have developed, was initially funded by Island Health. It was born out of an increased need for supports and services specifically created for the construction industry. The work of VICA's harm reduction team in creating a curriculum and dialogue for the industry was recognized by the BC government, and funding for the project was picked up in January 2022 to deliver this training throughout the province. The project targets anyone working in construction and trades who use substances and for employers who wish to increase harm reduction awareness in their workplaces. The goal of this project is to bring awareness and increase access to harm reduction services and ideas for those who work in the construction industry. This project is the first of its kind in the construction industry, innovative in that the project partners with Indigenous knowledge keepers, lawyers, an organization that supports people living with chronic pain, persons with lived and living experience, health authorities, managers, supervisors, and owners of construction and trades companies to break down stigma and provide training and education to meet the needs of our industry, and aims to reduce the number of toxic drug deaths in the province of British Columbia. There are three components to the toolkit. The toolbox talk is approximately 30 to 45 minutes in length and is delivered live on site, and we can do it via Zoom with our own, with VICA's harm reduction team. The talks highlight drug poisoning stats about the drug poisoning crisis, why it's an issue in the construction sector, why is it an issue for men particularly, the connection between mental health and substance use, physical health resources, mental health resources, harm reduction resources, recovery resources, and any other available sources, any supports that an employer may require. The talk can also serve as an operation for the distribution of naloxone kits and training on those kits. The second component of the toolkit is a training course for those directed at supervisory and frontline positions, and they're delivered over 2 full days or 4 half days. The training covers statistics about drug poisoning crisis, introduction to harm reduction as an approach, construction industry discussions, substance use and mental health, components of stigma, recognizing substance use and impairment, mental health first aid, mental health and substance use literacy, with a focus on having effective and supportive conversations, naloxone injection training, Indigenous perspectives, active listening, compassion, resiliency, chronic versus acute pain, pain management, stigma, and more through the summary, summary of services available. In consultation with local health authorities, the third component of the toolkit are digital and print resources for both employees and employers that highlight the harm reduction and recovery services that are available to workers within and beyond their benefits packages. These resources are a mix of provincial-wide and regional-specific resources that will contain identity-specific supports, including Indigenous-led organizations and an industry-specific support group. VICA's current harm reduction team includes trained regional facilitators that are positioned throughout the province in construction association offices. We call them RCAs. They're all trained social workers, working in collaboration with the provincial health authorities. Facilitators gather information on the programs and services available in their area and the province, along with information about the specific needs of individuals working and living in those regions. Currently, our BC Construction Association has reached over 12,300 construction-related companies. Facilitators offer training either virtually or in person, and the latter allows our project to reach even more communities where travel could be a barrier. In partnership with the Umbrella Society, which is a local substance support center here in Victoria, BC, the final component of VICA's project provides weekly meetings for folks in construction struggling with substance use. It's facilitated by 2 Umbrella Society staff who have both lived experience of substance use and working in the construction industry. From January 2023 to the end of September 24, VICA's harm reduction staff have had the opportunity to provide 230 talks, over 5,500 people working in the construction industry.
If I could get you to wrap up, you'll have lots of time to expand on your presentation and the questions and answers that follow.
Sure, and that would be summarizing our components, and I'll leave it there.
Thank you, sir. We are now going to begin with rounds of questions, starting with the Conservatives. Mr. Doherty, for 6 minutes, please.
Thank you, Mr. Chair. And if I can start off by saying, Mr. Chair, thank you for allowing our witnesses the time that they deserve to tell their story. I'm going to focus my my questions on Mr. Charles and Ms. McDonald. I want to thank you guys for your strength. And I don't know if I would have had the same strength that you have. And so I thank you for that. If you could send one message to Justin Trudeau about the failed drug policies, what would it be?
How can you put safe and drugs in the same sentence? Doesn't make any sense. Those two contradict each other deeply. And the policy, you should just look at those two words and it should tell you and give you an answer right there. Safe and drugs don't mix.
The system failed, Brianna. We just needed one adult to stand up in the room to fight for you. You begged doctors and you begged those people that should have been there to do no harm and to help your daughter. What was the message that you got?
That the help wasn't there. The doctors kept sending us away. And it kind of sent a message that really it didn't matter at all. That she didn't matter. And her mental health didn't matter.
I think I read somewhere that you were essentially told if she wanted to kill herself, that's her choice. Is that true?
Yes.
Very true.
Do you believe that Brianna would be alive today if she got the help that she needed, the mental health help?
I believe not only would she be here today, but she'd be able to speak out on her own situation and what she's gone through. I believe if the help was there and available, her beautiful smile would still be here.
And just to be clear, Brianna had just turned 13,
Yeah, just in July 15th.
so she was just a month into her 13th year. July 15th, did you say?
It's the same day as my son's birthday. And I should note that she passed away on my daughter's birthday.
What does Brianna's story say about the state of mental health care in Canada?
Pretty much that it's broken. The system that is designed to be there to help her and guide her through life, especially when it comes to struggling with mental health, it just isn't there. And whenever we did approach doctors about change and how to get her help, she was either too young for programs or there was no programs at all.
They allowed a 13-year-old to write their own safety release plans, is that correct?
Correct.
She wrote on that plan that she was a very manipulative little girl. And my question is, why was a child allowed to write her own safety release plan when doctors are supposed to be doing that? Because they're the adults. They're the ones deciding on how her safety is supposed to be, not a child, and not a child that's unwell.
And you were powerless.
Absolutely.
From the time she ended up on the streets to her death, how long was that?
Almost 4 weeks.
It was, sorry?
Almost 4 weeks.
And her drugs of choice were Molly and fentanyl?
Molly, fentanyl, anything she could really get her hands on. Molly was her
Molly was her DOC.
that was her drug of choice, yes.
Are safe injection, safe consumption sites working?
No.
Absolutely not.
No, they don't discriminate against age, and they keep providing kits to these children. And it's very easy access.
It's everywhere. You can't go anywhere without seeing it now. It used to be taboo to see a joint being smoked on the street. Now you can walk by people smoking crack. It's disgusting.
We sat at an A&W once having lunch. This was 12 o'clock in the afternoon, broad daylight. And I had to tell my stepson to literally not look out the window because there was 6 people sitting there cooking their heroin down to be able to inject it right out the window where we're having lunch. That's not acceptable. That's not what I call safe.
Have our communities become less safe in recent years?
Absolutely, and I believe they're getting even more unsafe as the days pass.
Thank you, Mr. Doherty. Thank you, Mr. Charles. Next, Madame Brière, for 6 minutes, s'il vous plaît.
Thank you, Mr. Chair. Mrs. McDonald, Mr. Charles, you have my deepest sympathy, and I share your pain. I salute your courage in sharing this heartbreaking story. What do you think should be done to involve parents in the prevention work in order to protect our Canadian youth?
Our children, we need to be able to stand up for them and advocate for them, not for them to advocate for themselves when they're too young. We are supposed to be their legal guardians. We're supposed to take care of them. We need to do so. We need that authority back.
And as it sits right now, we're just guardians of the government's children. They're not even ours.
Yeah, but did you know where to go to seek for help or to seek for services?
Absolutely, and I exercised every option that I had. I went to hospitals, I went to mental health places, we went everywhere, and we were basically told we have exercised all our options, and we are sorry, and we condole you, and we're happy for your best efforts. Thank you.
And the only gift they gave us really was an Narcan kit, which that's pretty alarming as a parent. Receiving a Narcan kit instead of, hey, here's a doctor's number, maybe these people can help. Social workers didn't have a clue, because and their answer to us was, our resources are so limited. And especially because of her age, there wasn't much they could do.
Yeah. So do you think that the services are more for adult, more targeted for adult than for youth?
I believe when the harm reduction stuff was brought in, that, there was an aspect that children weren't really thought of at that point, because really recreational drugs and stuff like that was more of an adult thing. But now, I hate to say it, it's reaching our children at a very alarming rate, and the children are suffering. And I don't think it's because they choose to do the drugs. I think it's because their mental health is really in the dumps, and it needs to be changed. Mental health needs to be changed, and so do these policies.
Thank you. Mr. Kulmala, can you talk a little bit more about the toolkit?
Sure. The toolkit was really generated at a time when we were trying to do the outreach to the construction sector. As I mentioned, about 52% of those workers that were employed came from our sector. The statistic when we started this back in 2017 was effectively 1 in 4 who were dying were in construction. And we generalized the construction, the trades, and the commercial, the blue collar workers. The idea was that, and again, I'm not professing to have a healthcare background. It was just, how can we convey information that allows people who would otherwise hold this or not seek help to find information or to get some sort of seek out attention or seek out treatment. What we found early on is when I initially had a harm coordinator come from the Island Health Authority, and we would do a lunch and learn and say, here's a 1 hour session. You could imagine when we invited workers to come to us, we got 0 people show up. And we found that a little bit concerning considering the statistics that were out there. There was also this perspective that this isn't happening to our industry. So there was denial. And it's taken 8 years for us to somewhat acknowledge this crisis does affect the construction sector, but more so it's a community, it's a social impact. We're just trying to do our part to reach out to construction workers. And through our strategy of outreach to companies, we also work with local community colleges that provide first and second year level apprenticeship training. Where we do our effort is to create awareness. And what's happened, Madame, is we've had workers who would otherwise stand there with their arms crossed at a meeting in the morning, and for your information and just for general awareness, a toolkit talk or a tailgate talk is something that generally happens all the time on a construction site. They start their day. We typically say it's around the tailgate of a pickup, and we talk about, we're going to be doing this work. There's going to be stay away from this area. These deliveries are happening. Well, now when we introduce this component, we've had workers who clearly are uncomfortable with the conversation, but by the end of it, they're saying, I either know somebody who needs to get this pamphlet, who needs to come to that support group. And we have a spectrum of care that suggests it's even things who have a heavy dependency on alcohol. We don't discriminate necessarily on the toxic drug or focus solely on the toxic drug. We focus on elements that would compel somebody to, go out and party one night, start with a couple of beers. Next thing you know, they're having a hit of heroin. And, we find that the circumstances, the circumstances are there that would suggest that there are ways to inform them of what they should be looking for. And then also coaching employers to say, don't let people struggle in vain. Don't let them go to, if you see somebody who's clearly having challenges, they may be sober or they may be of clear eye during the day, but at night they go home and they literally, they turn to a very dark place and they use drugs to cope, only to get up and do the whole thing over the next day.
Thank you, Mr. Kamala. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Merci, Monsieur le Président.
Thank you. Thank you, Mr. Chair. I would like to add my voice to that of the chair and share my condolences with you. We are here to try to find solutions to situations that are extremely difficult. And I believe that as we continue this study, we might need resources ourselves because we are impacted by this. There are people who die in the streets every day because of this toxic drug crisis. And behind these people, there are siblings, parents, friends who go through this as well. More than 45,000 overdose deaths, and we're looking for solutions. I stumbled upon some research because we need to look at data. Dr. Larney, I would like for you to share your study on intoxication and stimulants in Quebec. It would be great for us to have this document officially for when we move to the report stage. At the end, you state that there are a series of interventions to respond to overdoses. Supervised injection sites, safe supply, verifying medication. I imagine by that we mean drugs, the distribution of naloxone, opioid agonist therapy as well. And you also state that there needs to be further research in order to see regarding medication and safe supply that there are results that we could look into to see the efficiency of different measures. I would like for you to tell us more about this, because currently in Canada there is a trend, a political trend of taking a step back, being afraid to act, and for election reasons we talk about ending different measures. I would like to hear your opinion on that, please.
Thank you for the question. I'm happy to share the paper that you referred to with the committee. So one of the interventions that is being implemented across the country is safer supply, l'approvisionnement plus sécuritaire. And we are currently engaged in some work on reviewing the literature on safer supply. There is evidence, particularly from Dr. Bodan Nosik's team, who I believe the committee has heard from, that safer supply prescribing or risk mitigation prescribing during the COVID-19 pandemic was associated with a reduced risk of death. And this is very promising. More work, quantitative research in particular, on the impacts of safer supply is needed. I think it's very important to say that lack of evidence around an intervention is not evidence of a lack of effectiveness. Where we are at with safer supply at the moment is a lack of evidence in many cases. So we do need to see more quantitative work, such as that done by Dr. Nosik, very carefully designed quantitative studies evaluating safer supply programs across the country, the same way we would any new medical intervention. I think that withdrawing those programs would have devastating consequences for people who are currently part of safer supply programs. We know that safer supply programs are helping people to regain some measure of control over their life. At the same time, though, I do believe that we need more studies of what are the effective components of safer supply programs, and also considering the range of programs, because at the moment there are a lot of different models. And so understanding these different models and coming to a clearer understanding of what do we actually mean when we say safer supply, and what are the effective components of these models.
If we force people to receive treatment, some might think that that would solve the problem as quickly as possible. According to your knowledge, do you believe that mandatory treatment is efficient? And when you're talking about a reform of social policies, what exactly are you thinking about?
Dr. Larney, we're out of time.
I'm sorry, I missed the chair's comment there.
As brief a response as possible, please.
Okay. Compulsory treatment has been studied in a number of settings and is very ineffective, because treatment is not for a substance use disorder is not a one-off process. It is an ongoing and often relapsing condition that needs a more nuanced approach than a compulsory setting, which is typically one size fits all. In terms of social policies, I would argue that we need to look at the housing crisis. We need to look at income stagnation and income mobility, intergenerational income mobility, unemployment, all of these things that contribute to a strong social safety net that Quebec was famously, had in a way that other provinces were often quite jealous of, but has been somewhat damaged in recent years.
Thank you, Dr. Larney. Next, Mr. Johns, please, for 6 minutes.
Yeah, well, first, I want to thank all of the witnesses for their testimony, especially Ms. McDonald and Mr. Charles, for having the courage to come all the way here and share your story. Hopefully it'll help prevent deaths of young people. It shouldn't be happening. You talked about, I mean, if a child broke their leg and they went to the hospital, they wouldn't be denied because we don't have certain types of care for their broken leg. They would get the care. And we don't have parity when it comes to mental and physical health, largely because of the stigma, I believe. Do you believe that we don't have parity because of the stigma in mental health and in physical health?
In my honest opinion, yes. I believe there's a big stigmatism against mental health, especially among youth. I believe that it's been overlooked, and I believe that it's kind of been just put on the back burner compared to, again, the safer supply and the harm reductions. It's almost like it's gotten lost in the wind.
You mentioned that she was held for 10 days and then released. What type of care were you hoping she could receive instead of being discharged? And I guess what type of care do you think would have helped Brianna stabilize and recover?
I think if the doctors actually took the time to look into her mental health and actually assessed her properly, they would have seen how many problems she actually had.
You mentioned the lack of availability of mental health programs for youth. This is pretty clear. Do you think the government needs to increase funding for youth mental health supports, and do we need more education for healthcare professionals on youth mental health? Because clearly the professionals demonstrated that they weren't equipped. It sounds like.
I do agree. Yes, there needs to be more education. There needs to be more training for doctors and nurses. I do believe that there was one time that a doctor actually told us that she's too young to diagnose, which I kind of think is completely wrong, because in the States they are diagnosing children at very young ages and the process is actually working. So there must be some kind of separation between the two, and I believe that lack of education and lack of there should be more funding towards treatments and education for healthcare providers.
Having a child struggling with mental health and substance use issues it's extremely difficult on your family and on you as parents. Did you receive any support while you're dealing with these issues with your daughter? Are there supports that would have helped you and your children as you navigated the broken system when it came to dealing with Brianna?
We did receive a little bit of help, but mostly from a few social workers here and there. They literally exercised all their resources, and they even tried to pull some strings to make things happen outside the box, and they were so tied, their hands were so tied because everything was so limited. The little treatment centers that we would have had to pay out of pocket wouldn't accept her because she wasn't of a certain age. So yes, we did receive a little bit of help, but again, there was no programs or anything that were actually available for her and her situation.
I'm sorry for your loss, and for Shayton as well, his family.
Thank you.
Dr. Wyman, I really appreciate you being here and joining us remotely today. From your perspective, is the federal government doing enough to address the intergenerational trauma arising from colonialism and residential schools? And do you believe First Nations are getting enough resources from the federal government to meet the demands for culturally safe mental health and substance use care? I think you know that there's a mental health emergency declared by the Nutchala Tribal Council in my riding. Maybe you can speak about what also the barriers are in accessing federal funding, including the SUAP applications that have been rejected across British Columbia.
Thank you for the questions. I think to start, I just want to express my deepest condolences to Mr. Charles and Ms. McDonald for sharing their testimony. I think I'll start with saying, for First Nations people, most often the underlying reason why people choose to use substances is trauma, their mental health state. Whether that's historical experiences, contemporary experiences of trauma, intergenerational experience of trauma. People use substances because they want to change how they feel. And that's probably very similar for other people other than First Nations people. Here in British Columbia, of course, we are quite concerned, as I shared the data for First Nations people in BC, particularly the decrease in life expectancy, mainly driven by the toxic drug crisis public health emergency. And as you've mentioned, the various states of declarations of emergency regarding the toxic drug crisis in different areas across the province by First Nations communities or tribal councils, etc. So in answer to your question, I would say, I think we feel that the level of funding that we could leverage against the toxic drug crisis broadly probably isn't there. And, for example, I've said before that the amount of funding that was directed to the COVID-19 pandemic compared to what has been allocated for addressing a now into its 9th year public health emergency, where we have lost many more people due to toxic drugs than we had to the COVID-19 pandemic, sort of says something. And I think we've already spoken at this committee about stigma.
Thank you, Dr. Wyman. Next, Ms. Goodridge, please, for 5 minutes. Mr. Doherty for 5 minutes.
Thank you, Mr. Chair. Mr. Charles, Ms. McDonald, why did Brianna start using drugs, and at what age did she start?
She started using drugs at about 10 and a half, shortly after me and her stepfather broke up, and she just wasn't handling it very well.
And she also wanted to drown out the demons and the voices that she kept hearing.
Okay. Is safe supply really safe?
How could you have safe supply and drugs in the same sentence? There's no such thing as safe drugs, period.
Would safe supply have saved Brianna?
No.
Do you feel that Brianna was a victim of failed drug policy?
I feel it isn't just the failed against the drug policy. I feel she's failed by the system, public health system as a whole. There was many different layers of failure. That was just one of them.
Can you tell us a little bit more about Chayton?
He was a loving little boy, very gentleman.
Him and Brianna would sit on the phone for hours, conversating back and forth with each other. They just absolutely adored each other. They were best of friends. Mm-hmm. They've known each other for the last few years and have fed off each other, good and bad.
Yeah.
And he really took it personal, and I really feel sorry for that.
What can the federal government do to make sure tragedies like Brianna and Chayton never happen again?
Make changes to the public health policy. Start giving more funding and providing more educational backgrounds for these health workers that need it. Doctors, there needs to be more training. To be honest with you, it seems like, mental health in children is being overlooked. And these doctors and psychologists and psychiatric care people, there's just not enough that they don't understand. Like I said to Mr. Johns, down in the States, they are diagnosing children with mental health. Why can't we do that here in Canada? What's the difference?
You said that the drugs in our community are getting worse and worse. Are you seeing the diversion of safe supply into our into the hands of our kids and into the neighborhoods in Abbotsford?
Let's put it in this perspective, Mr. Doherty. When a child can go up and get a bag of items to do safe injection and prepare their drugs and literally walk out that door, there's a drug dealer standing right there. Just like what happened in Nanaimo just recently. They were given the safe harm kits in the front, and out the back door the drugs were flying.
Wow.
So I think that is enough of a statement to prove that, yes, it's becoming alarming.
I've got about a minute left. What else would you want our nation and those in this room to know about Brianna?
That she's a very loving, beautiful, caring girl. She was taken way too soon. She was so compassionate. She had so much potential. She was so smart. She loved to research everything so much. And I wish she was here to share her side of the story right now.
She was robbed of her life, and I feel that she had so much potential to being a powerful individual because she always took other people's problems and she made them her own, and she took it seriously. It didn't matter what it was, how big or small. She was a powerful individual, and I believe with the right education and treatment, and she was able to finish schooling, I'd feel she would be a perfect fit to be in this room with all of us. She was that intelligent.
Thank you for sharing that with us, and thank you for being with us today.
Thank you.
Thank you, Mr. Doherty. Ms. Kayabaga, please, for 5 minutes.
Thank you, Chair. I would also take this moment to thank Mr. Charles and Mrs. McDonald for your courage to share your story with us and to continue to advocate for your daughter even after she's no longer with us. I think her siblings are probably very, very proud of the two of you and the courage that it takes to do that. I do want to know, you did mention, Mrs. McDonald, a bit about the genesis of her journey in this. What else do you think the federal government could have done to support the province to prevent her starting on this journey before we get to her use of drugs?
I think there need to be more mental health in place for her, as she did talk to people and stuff, but I felt like she was very overlooked by a lot of them, and they weren't actually listening to her in the bigger picture. They were just listening to what was just in front of them, not the whole story.
And do you feel that if there was earlier prevention in her mental health journey, the pathway for her could have been completely different?
I think it would have been completely different. I don't think she would have been drowning out those noises that she had in her head. She wouldn't have been so sad inside and felt so heartbroken and so distraught that she wanted to take her own life.
Do you think that there should be more supports for children like Brianna in schools, everywhere, to be able to, especially if there's some major shift in their lives, like a parent separation? Do you think that these are things that we could implement into our education system from the provincial level?
I do think they could be implicated a little bit more. I know there is some people like counselors and stuff in the schools and stuff, but I do think that it could be more.
And do you think that addressing some of the stigmas that are around families that are going through some shifts could also help the children better navigate their mental well-being while they're witnessing that.
I do think so, yes.
I want to thank you both for being so courageous to answer our questions. I'm going to shift my questions to Mrs. Laney. Mrs. Laney, you did talk about, you published a paper regarding some of the provinces like Quebec that have been sheltered from overdoses epidemic. Could you talk about the factors that led to this and why it's no longer a case?
Certainly. So we see the increase in fentanyl and other substances entering the drug supply in Quebec. It actually began slightly before the COVID-19 pandemic, but then the pandemic really created the conditions that caused chaos in the drug market, essentially. And when you have that level of disruption and new players entering the market, new substances, and this is when we start to see significant increases in deaths. And so that's the kind of acute cause of what happens. We have this change in the drug market away from the sort of reliable supply that had existed beforehand to a much more unpredictable supply, much more similar to what is seen in other provinces.
So I come from a community like London where we have been grappling with this opioid crisis way before the pandemic, and I think it has increased, but there were times where we could look to harm reduction or harm reduction from these toxic drugs as a, as a proof that it saves lives. Like, we have numbers to prove that. What do you say to people who still need more data and information to prove that harm reduction do save lives?
Yeah, I think that there is an enormous amount of evidence that harm reduction is an essential part of the response. And if I can come at this from a slightly different angle, I think that one thing that would be helpful is to consider that we don't have to have harm reduction or other options, other health interventions. This is about providing wraparound care that meets people where they're at. And that includes harm reduction for when that is what people need to keep them alive, right through to various treatment options, mental health care, supportive housing, the whole range of services that people really need. I think that positioning harm reduction and other opportunities, other interventions as opposites and not actually working together is a false dichotomy.
I just get for clarity for the purposes of myself and other people who may not have this answer, what is the age restriction for safe consumption sites? Is it the same policy across the country, or does it differ from province to province?
I believe it differs from province to province, and I would not have the exact numbers to hand, so I would not like to speculate.
Okay.
Thank you, Dr.
Could
Larney.
you maybe sorry, Chair?
No, that's your time.
I just want to ask if she could submit that in once she has the information to the committee, so that
certainly
we can
I
have
can
the
do that,
information.
yes.
Thank you.
Yeah.
Monsieur Thériault, pour 2 minutes et demie.
Mr. Thériault, you have 2.5 minutes. Dr. Larney, if we talk about the social determinants of health, and we talk about illness, the pandemic exacerbated the issues with our health system, which has been chronically underfunded for decades. Is this a statement that speaks to you? And I say this because when you shared your conclusions and stated that we'll have to act on social policies and on the social determinants of health, well, that can't be done overnight. And organized crime is opportunistic, and the pandemic made it so that it was able to adapt. And so we were not able to act on mental health and haven't been able to do so since before the pandemic. If you can comment on all this. Is this something that makes sense?
Yeah, yes, completely. I think that the strained mental health systems and the broader physical health system as well, in terms of people with chronic pain, such as people in the construction industry. I think this is coming through from all of the witnesses, that there is a need for greater resourcing of healthcare, mental health care, that can be implemented before people are in a situation where we're needing to prescribe safer supply. Absolutely.
J'ai fait une bataille sans précédent pour
I fought for provinces and for Quebec to receive an increase in health transfers to meet or to help them overcome the challenges that they face. And I have already stated in the House that I found it criminal to give only $46 billion over 10 years in increases in new funding. Do you agree with my opinion?
Well, I would have to say that I probably am not as familiar with the details as yourself. I think that it is true that the Quebec health systems are crying out for funding, as are all health services across the country.
Thank you, Dr. Larney. Mr. Johns, please, for 2.5 minutes.
Well, thank you. I'm going to go back to Dr. Wiseman. Dr. Wiseman, I really appreciate you talking about the comparables with COVID. I mean, the federal government spent less than 1% responding to the toxic drug crisis than to COVID. We've now lost more people to the toxic drug crisis than COVID, I believe. We've seen death rates in neighboring provinces. In Alberta, they just had a record amount of deaths last year. Alaska, a neighboring state, 45% increase in deaths, now a higher death rate than British Columbia. Baltimore, it's 5 times that of British Columbia. All places without harm reduction, pretty much no safe supply, no decriminalization. I guess what I'm asking is maybe you can speak about your earlier comment about the impact of politicization of this crisis and the impact that's having. And also, I was in Portugal last year, and they talked about the fact that it was experts that led their response, not politicians, and the politicians got out of the way. Can you talk about the role politicians should be playing and experts, and how we can move forward with less politicization?
Thank you for that question. I think as a way of responding, I will say one of the things that we have observed in British Columbia is that a lot of misinformation is being spread in the public realm around the toxic drug crisis and interventions directed at trying to save lives. So that misinformation is really harmful and has the potential, should, for example, supervised consumption sites be closed, as mentioned by Dr. Larney, the effects of that would be devastating. We at First Nations Health Authority are in support of a full spectrum of prevention, harm reduction, detox, treatment and recovery, and aftercare. And I think what happens with the spread of misinformation for purposes other than for politicization purposes, is it leads people, it increases stigma, for example. People using the term drug dens to describe supervised consumption sites is really abhorrent. These supervised consumption sites, the body of evidence supporting lives saved is very strong. And for example, I'll say we've used the broken leg analogy already in this committee. We have centers that provide dialysis, for example, to people in kidney failure, so they don't have to travel long distances. We don't call those dialysis drug dens. We do because of the stigma against mental illness and people who use substances.
Thank you, Dr.
And I
Wyman.
think that has not proven to be very helpful, has been harmful.
Thank you, Dr. Wyman. Next, Mr. Viss. I understand you're going to be splitting with Ms. Goodridge?
Perhaps. Thank you,
Okay.
Mr. Chair.
You have the floor, sir.
As the local MP for our community of Abbotsford, thank you for being here. You mentioned the Cyrus Center. I live just off George Ferguson. This is around the corner of my house. Thank you for sharing your story. If you could send one message to the Minister of Mental Health and Addictions about some of the failed drug policies we have in Canada, what would that be?
That we need more help. The healthcare providers need way more help. There just isn't enough. I get it, there's an opioid crisis going on and there's a lot of people dying from drugs. But the mental health aspect is a big leading factor. And we can't overlook mental health. Drug use and mental health issues go hand in hand. And in order for it to stop, we need more funding.
As you know, the government of British Columbia and Canada signed a special agreement for decriminalization of hard drugs in British Columbia. Is it your experience that it became easier for children to get drugs since decrim began? And how did Brianna generally get her drugs?
I believe it did, actually. The decriminalization of drug use and possession of drugs actually increased the drugs coming to British Columbia. It lowered the prices. It made it easier to acquire because, hey, your mental health medication, a lot is experimental and you have to pay out of pocket. And it's not always covered. But the drugs can replace that, and people were replacing the mental health pills and prescriptions with the hard drugs. And as per Brianna getting her drugs, she used a lot of it through 16 and 15-year-old kids. And these 16 and 15-year-old kids they actually got really ballsy and showed up at our house one evening. Wow. And I actually had to escort them out of my neighborhood.
I'm just going to ask one more brief question and before I turn it over to MP Goodridge. But as a parent in the public school system in Abbotsford as well, what role does the Abbotsford School District have to play in keeping our kids safe?
I feel there should be more police liaisons. I feel they should be checking the children before they even come to school. If found with drugs on them, they should be punished and realize that it is wrong and they shouldn't be having access to these drugs. Nobody should.
Thank you. Thank you so much for sharing your daughter's story with us and being here. So Justin Trudeau has brought forward the most radical drug policies our country's ever seen. And as you said, flooded the streets with hard drugs, made it so that it was legal for kids and adults to have crack, meth, and even your daughter's drug of choice, Molly or ecstasy. Do you believe that the policy choices that were made by this Prime Minister attributed to your daughter's death?
Yes, I do. To be honest with you, I feel like this experiment, and I'm going to call it an experiment, was directed towards our children. It was directed towards the people that were struggling with mental health. And the fact that she was able to acquire these drugs on a massive level and very easily at her own age, I do believe his policy is what really, led to her death. It's not just his policy, it's the fact that there's lack of funding for the mental health.
So if you could tell him he has the ability with a stroke of a pen to change these policies today, do you think he should?
Absolutely. To be honest with you, we need to protect our children, and he needs to start realizing this. To protect our children, to save the lives of, beautiful, innocent people that deserve this. These are our children, and myself being status First Nations, it is our job to protect them. And it's his job to help us protect them. Why can't he do that? Put the pen to the paper. let's get more funding for the people and the children, and let's stop this, and let's do it all together from the top right down to where we are as parents.
Thank you, Mr.
We
Charles.
need more rights.
Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Mr. Chair, I want to share my time with Dr. Pulaski. Thank you, all the witnesses, sharing your knowledgeable testimony, and my sincere condolences to Ms. McDonald and Mr. Charles. Thank you for doing advocacy. So my first question is to Mr. Kolmala. Mr. Kolmala, Public Health Ontario found in 2022 that almost 1 in every 13 opioid-related deaths in Ontario was a construction worker. Why is that happening? Why is the opioid crisis hitting construction workers so hard?
I think the biggest contribution that we see is we have a similar demographic. Now, outside the tragedy that happens to children, we know that the main demographic is 19 to 52, and we also know that the barriers to entry into construction are rather low, particularly in the skilled trades. But there's a continuum of just laborers that working there. It's an accessible career path for many individuals, but there's a lot of things that happen when it comes to pain management. It can be a stressful job, but it can also be, it's that work hard, play hard attitude. It's the bravado of particularly men who don't want to seek help, so they self-medicate. They look internalized to try and treat their own challenges, and where there are, elements of mental health. Again, they don't want anybody to know it. They have livelihoods to provide for. It's a good industry where there's good income. It provides access to people to get funds. In some of the statistics, we see that, that the amount of people in the construction sector that die from an overdose or from a toxic drug exposure, it's happening in a place of residence. So, they are with means. So we look at between mental health, between pain management, between the work hard, play hard attitude, and then the social element that can come with it. I think it contributes to a disproportionate amount of people in our sector falling to toxic drugs.
Thank you. Last summer, I speak to Luna members from Brampton this year about innovative programs to raise awareness and reduce stigma around substance use and mental health among construction workers. Could you share with us, you told you are working with the 12,000 organization from BC, the focus on employer and employees, so peer support is there. If you can talk about some similar programs, can you elaborate on that?
Well, most of us trade industry associations are trying to find ways that we can connect with employees. And, we do try to do, ours is a little bit in a nuance that we actually go to the job sites, and we'll do this anywhere in the province of BC. We've done it up in the north. We'll go to any job site at any time to do this tailgate talk. We're also available as a resource to say, hey, I need some information. And again, trade associations or industry associations are active. This is front of mind. So we're all looking for innovative ways. I think the difference that I see with other trade associations, it tends to be web-based. So you have to actually go online, log in, do this program, and it will help you. There's 811. We have a number of resources that we give out to people that are in crisis to say, here's the subscription of services in your area that you can access. We're finding that that people are reluctant to go to a website, that are reluctant to actively, seek out some supports. But we find if we go into them and we talk to them and we give them a card and we put it in their hand, they may not say, it'll be I've got a friend that might want that. That might be them. And because it's a very personal matter, we don't get a lot of feedback from people that say, you saved my life, but we do get people that say, look, I'm glad you gave me that because now I know and I feel better about it. Similarly, our employers are saying, look, thank you for that information. We have there's nuance in legislation around duty to accommodate. So what does that mean? We explain it, and companies are now saying, we got to take care of our workers.
Lance, Sarah, I was a longtime emergency room doctor. I'm sure in BC there's the same kind of laws as in Ontario, whereby the emergency room doctor has the ability, and I would say has the obligation, if they think that someone it presents a harm to themselves, a harm to others, or is unable to look after themselves, they can require a person to stay in the hospital for 72 hours for psychiatric evaluation. How many times did you bring Brianna to the emergency room, and how often did they use that power to keep her and have her observed and at least enter into some sort of treatment?
There's over 20 recorded just in a short time, suicide attempts and self-harm attempts. It got to the point where myself and her father actually pulled a doctor aside and said, don't fall into the narcissistic, manipulative ways of her. She will talk herself out of here. Please take our pleas and keep her here. She needs the psychiatric evaluation. And of course, you know, they kept telling us the same thing. We'll do our best. And shortly after, they kick all of us out of the room, talk to her. Nope, she's fine, and send her on home.
So how many times did they keep her?
That's your time.
Twice.
That's your time.
20 times.
Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. So just to follow up on the questions from Dr. Pawlowski, so they only kept her 2 times in the 20 plus times you took her into the hospital for suicide attempts, is that correct? How often, like, when you're dealing with this kind of situation, I am assuming that there are many times that you didn't have the opportunity or you chose not to take her to the hospital. How often were you dealing with this, and do you feel like enough was being done to help you?
This was going on daily, and her attempts were almost weekly at the end, if not every other week. They were pretty bad, and we didn't go to the hospital quite often because we knew we would just be sent home and it was a waste of time.
I'm so sorry. I'm going to switch gears a little bit. Mr. Kumala, your tailgate toolkit includes resources for people to be able to access what you call safe supply. And so my question is, are workers permitted to use safe supply while on the work site?
No. No, and I think there's an underlying requirement. We have zero tolerance for impairment on a job site. And again, we haven't seen, and I can say that I haven't had a report of somebody actually dying on a job site who's actively using. Again, this is, and I'm sure from a medical point of view, the levels of impairment are broad, but we don't accept that on a job site.
So you do not allow employees to use drugs on the work site. You're a safety-sensitive employment location, and so you think that this safe supply is just good for other people to use? I'm confused.
No, I think what we're trying to do is provide the resources are available. We're advocating for wellness, and where there are safe supply, where we're, telling people when they get home, if you're going to use it, there's a way to stay alive. And as I've said before, we're just trying to throw them a life ring. We're not teaching them how to swim. That's not our job. Our job is to provide awareness.
So, what funding do you receive from the federal or provincial government in British Columbia?
We receive funding through the provincial government from the Ministry of Ministry of Health and Addictions to provide the tailgate throughout the province.
So if an employee were to get into an incident of some sort, test positive, they have hydromorphone in their system, what's the next step?
Well, the next step would typically be through their health and safety processes with the particular contractor. Again, it's not about trying to give them an opportunity at the job site to get high.
Okay, so is the next step often referring them to treatment?
It could be, but the first thing is to suspend them. If they're clearly impaired on the job site, they get suspended. Then there'll be a path of investigation to suggest treatment or, other employment remedies.
Oh, okay, so effectively, there is zero tolerance for drug use on site, but you do give people the tools for if they choose to use drugs to do it, but you tell them that they're not allowed to use drugs at site. I feel like this is a bit of a revolving door of interestingness. So how do you actually support employees that are coming back that do choose to take treatment?
Well, we're an industry association, so we're just advocating. We provide basically a workbook of resources of where they can go. This is determinant at the employer level, how they can treat them, what they do, and how they support their workers up to them, not us as an association. We are basically taking the tools that are available, that are out there, putting them into some type of resource package that says, here's what's there. Whether we like it or not, whether safe supply, we're not here to debate that. We're here to say, here's what it is, here's how you can get help.
Do you think there should be more resources available for treatment?
Oh, clearly. I think when it looks at the remedies of pain management, mental health, those are all stemming to really drive, and again, that's a personal issue. That's nothing to do with the construction sector, but yes, there is lots of room for improvements. I think as we've heard from Mr. Charles and Ms. McDonald from a very young age, and certainly with the doctors on the panel, there is opportunity to make this better.
So you're promoting drug use in your toolbox toolkit, your tailgate toolbox kits. Do you also promote treatment from addictions?
We're not promoting treatment, madam. We're promoting awareness. We're promoting information that people, if you do need help, this is where you can get it.
So
thank you. Thank you, Ms. Goodrich.
Sorry.
Next, Dr. Hanley, please, for 5 minutes.
I want to echo my colleagues around the table in thanking you, Mr. Charles and Ms. McDonald, for having the courage to share Brianna's story, particularly when the experience is still so raw and the grief so fresh. One of the most compelling things you said in your very compelling testimony was that Brianna was using drugs to self-medicate. And there, I think, lies one of the key links between mental illness and drug use. And I wonder, if you look back, Ms. McDonald, you mentioned the breakup when she was 10 and a half, but if you look back on Brianna's short life, when was the first opportunity, do you think, for intervention, and was that intervention available and accessible?
I think the first intervention was probably when she was about 11 years old, when I found her actively smoking weed the first time I caught her. And we tried to put her into a treatment center then. She didn't feel that she needed to go because she didn't feel it was a hard enough drug.
Thank you for that. Dr. Wyman, I really thank you for your testimony, and in the Yukon of, according to the chief coroner, in 2023, of 20 deaths from toxic drug overdose, 14 were First Nation. Again, that echoes the disproportionate impact on First Nation communities. I wonder if you can describe some successes that could be emulated, particularly in the area of prevention or land-based healing or aftercare, that we can learn from what you've observed.
Sure, thank you for that question. I think around the province of British Columbia, as I mentioned, we're broken into 5 different regions, and our regional teams, each of them probably have a story of a community or a grouping of communities that has a success story to share. I think one of the things we hear the most as a motto really is culture saves lives for First Nations people. And so we advocate very strongly for a model that both respects Western medicine and what clinical medicine has to offer, but also what traditional healing, ceremony, and being on the land has to offer. And so there are examples of that around the province. I think the other thing Another example, is Shiam First Nation in the Fraser-Salish region was the first First Nation community in British Columbia to have an overdose prevention site located on reserve. And I think that took place after a lot of discussion within the community and a realization that because of the number of deaths, that something had to be done. And one of the things that our role is at FNHA is to also foster that community communication. So, for example, Tla'amin First Nation on the Sunshine Coast has spoken publicly about their success in bringing the number of deaths down due to toxic drugs over the last several years. And so we're looking for an opportunity that they can share the learnings that they have with other communities, not just within Vancouver coastal region, but with the other regions of British Columbia. So there are, peer reduction programs. We have had different harm reduction grants. We gave out 108 harm reduction grants last year. And we have an opportunity at different gatherings, for example, for those communities to share what they did with the money, for example, and how that improved the situation in their communities. So we do track that and we share it at different fora.
Thank you so much for that, and certainly I'm sure the committee would be happy to receive any specific experiences from First Nations in BC on some of these successes, so they can be emulated and shared. Briefly, Dr. Larney, you talk about some overall trends in Quebec versus other provinces and what you see coming, but Quebec still has, I think, a remarkably low relative overdose fatality rate compared to peer provinces. And I wonder, are there protective factors at work in Quebec that are playing out differently than other provinces?
Yes, certainly. I just first will correct a point of fact. Decriminalisation in British Columbia did not extend to people under the age of 18. In terms of Quebec, one of the things that has differed in Quebec specifically compared to other provinces is there has been traditionally a preference for stimulants. So particularly cocaine is a long-standing preference for cocaine versus opioids in Quebec. And so that has somewhat perversely perhaps been protective against opioid overdose deaths. Because though the drug supply now is so contaminated and so unpredictable, that sort of protection is no longer present because basically all drugs now have a much higher risk of overdose because of contamination with fentanyl and other substances.
Thank you, Dr. Larney. Sorry to cut you off, but we're well past time. Monsieur Thériault, 2 minutes et demie, s'il vous plaît.
Monsieur le Président.
Mr. Chair, earlier we were talking about accessibility that young people have to drugs. A very credible radio station in Montreal, 88.5, stated, and you will remember a witness, Marie-Ève Morin, Dr. Marie-Ève Morin, who testified here. Well, that radio station stated that Dr. Morin realized that Meta was authorizing ads on illicit drugs on its platforms. She reacted. She reached out to the team at Meta to close those accounts, and she was not able to do so. When she shared this information, her account was closed. And I hope that for all of those who are concerned about accessibility to drugs, will stop sharing ads on those platforms. It's one thing to share and another to boost these ads. I wanted to share that. I found it important to share it this morning because these platforms are being used by young people. And it is unacceptable that we tolerate this and that we encourage a company like that one. Thank you.
Merci, Mr. Thériault.
Thank you, Mr. Thériault.
Next, Mr. Johns, please, for 2.5 minutes.
Yeah, I'll start with Mr. Kamala. First, I want to commend you and your industry for your leadership on, investing in prevention and education. We don't talk enough about prevention and education. Can you speak about some of the success that you're finding through the tailgate toolkit, which is very popular on Vancouver Island, where we both come from, and also maybe can you speak about the loss of income, as possibly being a barrier for those that want to seek treatment, and do you believe there's an opportunity to provide income supports for those that want to seek treatment that need help?
Thank you. I think the success we see is really about the interest in that our industry turning to actively seeking out the tailgate toolkit. They want to see what can they do to support their workers. And we do get people firsthand expression of how the program has helped them create awareness, or to say, again, I know somebody that I can use this with. As far as the income replacement, there are mechanisms for employed people through their health and benefits plan that if they have to take a leave of absence to have mental health or have any kind of care that supplements their income, short-term disability, long-term disabilities, and that's why we advocate for employees to have not necessarily a robust healthcare benefits plan, but a benefits plan. When it comes to people that are outside of that, there's always opportunity. People that are that need to supplement, they have a mortgage, they have a family to take care of. That just feeds to mental stress if they can't do that.
How much time do I have left, Mr. Chair? Okay, I'm going to turn my time over to Dr. Wyman. Is there anything that you'd like to add that you maybe heard today, or you feel a message that needs to be heard by the federal government to help tackle the toxic drug crisis?
Thank you for that. I'll be brief. I think just what I want to leave you with is an understanding, as I've said earlier, that the toxic drug crisis of 2024 is not the toxic drug crisis of 8 or 9 years ago. The current unregulated supply of drugs is very dangerous and potentially lethal. And I also think that most people who are interested in saving lives are advocating for the whole range of services, all the way from prevention, education, awareness, to harm reduction, to detox, to treatment and recovery and aftercare. That's what we advocate for at First Nations Health Authority. And so this, as mentioned by Dr. Larney, this attempt to create a false dichotomy between either or, that harm reduction and treatment are mutually exclusive, is false and harmful. I think the other thing that needs to be understood is there are nuances to this toxic drug crisis. People who use substances come from all walks of life, and I'm really glad that Mr. Komala was here today. So there has to be an understanding of the shades of gray around the toxic drug crisis, that there are many different stories, many different pathways to better health and wellness for people who use substances.
Thank you.
And so we have to acknowledge that entire spectrum. Thank you.
Thank you, Dr. Wyman. Dr. Ellis, please, for 5 minutes.
Well, thank you very much, Chair, and Mr. Charles and Ms. McDonald for being here. And I apologize for not being here earlier, but I have read your testimony, and thank you for that. Thank you for telling Brianna's story to Canadians. I just wanted to really focus, if I might, on, now I realize you're not experts in this, but you do have obviously significant lived experience, but if you had to design a system talking about a couple of things, prevention of drug use and then rehabilitation afterwards, what advice would you leave us here and for all Canadians?
Well, it's not all about, time. Time is the key, honestly. The more, it's all based on how these children are. Every child is different. Every person is different. There shouldn't be a time specific. If it takes longer, they deserve longer. If if treatment isn't working, there should be a broad spectrum availability of research just to be able to develop treatments for other people. Some do work for other, some, but not all. It can't be just a blanket. It needs needs to be research, and there needs to be a lot of time put into deciding which paths to move forward. I don't think there's one solid, good answer, but I believe that if time, structure, education, all of these things were followed, there'd be a good program in place, and this stuff wouldn't happen to our children and our people.
Thank you very much, Mr. Charles. When we're talking a bit about prevention, obviously this is the Health Committee, but that falls under perhaps education. Do you believe that there should be programs in schools to educate kids on the harms of drugs and that type of messaging out there, what drugs look like, what they can do to you? Do you have any thoughts on that at all, sir?
I do think that there should be some sort of, because there is for sex ed and stuff, why isn't there for drug education?
I'm with her on this one, but at the same time, you have to be sensitive. These are child's minds. They are undeveloped. They don't deserve to really know these things just yet. Maybe in the teenage years, yes, but it's the same thing with the sex ed programs. They're teaching them younger and younger these days, and this is just now allotting for children to think, hey, look, I can think like an adult. I'm learning about stuff that adults know. It's making them comfortable, too comfortable. So I believe the education should be there, but very sensitive to what the child's mind is, because it is undeveloped.
Thank you very much. That's an excellent point. We have to be cautious with the messages we're giving and at what ages. I think that's very well said. Maybe if we turn our attention a bit to looking at the criminal element in this entire problem. Again, what advice would you give to the Canadian government to say, you know what? Obviously, there's a criminal element here. People are selling drugs. People are making them illegally, etc. Do you have any ideas, perhaps, around punishment and jail time, et cetera, efforts that we're making on that front that should be different?
I believe the criminal justice system should actually be a little bit more strict, and actually should really crack down the whip on these drug dealers and people that are selling drugs, and especially to children. I believe that this revolving door that's happening, and this system that's actually failing these, because these criminals are getting locked up for a couple months at tops, and then they're back out, and they just keep doing it back and forth nonstop. They don't care, because they're making money, and that's all it is about money. I believe that stricter policies should shut this revolving door. If they are caught doing it, more than once, there should be an indefinite suspension, that they should be kept there, because these are the people that are killing our children. I feel that, these policies that are in place right now need to be really updated a lot. I feel the justice system needs to stand strong and stand by the people that matter, and that is the parents of these children that are dying.
Thank you, Mr. Charles and Dr. Ellis. Last round of questions for this panel will come from Dr. Pawlowski, please.
So continuing with my earlier line of questioning, you brought Brianna to the emergency room more than 20 times. They only kept her twice of all those times. Now, as I said, the emergency room doctor has the power to keep someone who's got a mental illness and presents a threat to themselves, or is unable to look after themselves. They have the power to keep them involuntarily in the hospital for at least up to 72 hours. I would say they also have the obligation to do that, and the obligation is twofold. The obligation, when people tell me, well, what about my rights? Well, the obligation is from the doctor and for society to intervene with those people is One, to protect people from themselves, because with time, people will often get better, and they may be going through a bad time, as Brianna was, but often, with the chance and with time, they'll get better. So you intervene to protect them from themselves. The other reason you intervene is to protect them, protect the families, like yourself, who suffer the long-term consequences. So I would say the medical profession, the emergency room doctors had an obligation to act and to keep her had they thought she was actively, basically suicidal. Why did they not keep her?
I believe they didn't keep her just because she was that manipulative of a person. She could literally look at you and tell you she's fine, and you would believe her. She was very talented in that department, and the manipulation actually it was so strong that she could tell anybody anything, and they would believe her. There was no. Even when we warned the doctors in the emergency room that, you know, her manipulation skills were absolutely amazing, I don't think they believed us. And honestly, that's what it is I don't think they actually believed what we were telling them. And they thought we were just trying to drop a problem onto their lap. And honestly, I don't think their response was a proper one. And yes, they are obligated to keep her.
Yeah, so I would suggest perhaps you were not very happy with the quality of care you received from the doctors, that you warned them that she was manipulative. Clearly, she'd had repeated attempts which put her life at risk. And frankly, I would suggest that the care you got in the emergency rooms was not good. Did you complain either to the College of Physicians and Surgeons or to the hospitals or consider legal suits as a result of her treatment?
It's been in discussion about legal pursuits. It's been in discussion of how to approach the situation, especially with against doctors, especially at CAPSU, Surrey Memorial, especially when, you know, Brianna's sitting there putting a pencil through her hand and the doctors are telling us she's fine to come home, the psychiatrists, you know. And Sarah advocated so deeply to keep her there. She basically cried. And the doctor literally looked at her and told her, no, we're not keeping her.
In society and with the legal system, I think there's this kind of balance between recognizing individual autonomy and individual rights, and what role, if any, does the society, do other people, do families have to intervene? Do you think that we've got, within the healthcare system, within the judicial system, do we have that balance right? Or do you think we've given too much power and autonomy to people with mental health problems and are unwilling to intervene where we ought to be willing to intervene to protect those people?
I honestly think we've given too much power to the individuals that are mentally ill. I believe that we need to start drawing that back and be able to speak out and be an advocate.
And Sarah, you look like you wanted to say something. No?
Thank you, Dr. Pawlowski, and thank you to, a heartfelt thanks to all of our witnesses for being with us here today. Colleagues, before we move to adjourn, there's one housekeeping item I'd like to dispense with. In connection with the brain injury study, can we set a deadline for the submission of briefs? I would suggest October the 16th. Are we okay with that? I see heads nodding around the table. Is it the will of the committee to adjourn the meeting? We're adjourned.